Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
As David said, I'm going to talk about the Dapivirine. I haven't talked about the Dapivirine. I don't know a lot about the Dapivirine. It's not in any of our guidelines, but it's at the FDA right now. So I thought, well, and it's been at the FDA since March, I should probably learn and share and help us all figure out how it's going to fit in. So with the caveat that most of these slides were taken from Sharon Hillier's talk at this year's HIV Principles course. So credit to Sharon for sharing her slides with me. I've adapted some of them and tried to simplify them. She is fabulous. If you get a chance to listen to that talk, I would encourage you to do it. In addition to the Dapivirinering, talks about microbicides and other things, but I'm going to focus just in the next 15 minutes on what is likely to be FDA approved. My disclosures, as always, I attended a few years ago the Latinx and Hispanic PrEP advisory program that stays on here for this year, I believe. As we've talked about, at least as of today, only FTC TDF and FTC TAF are approved by the U.S. Food and Drug Administration and only for daily PrEP in some and not all populations. And we are going to talk about things that are not FDA approved. And my shout out to Dr. Hillier. So one of the things that she says, and I think we all agree on, is that regardless of what we're talking about, that having more options gives people more choices and can often lead to better choices that fit people's situation. And so this is just a slide showing all of the possibilities for what we are hoping to have for HIV prevention. We know that in contraception, it is true. Lots of options give people better ways to fit the contraception that they want in their lives. So right now, all we have is oral PrEP. We are soon to have injectable PrEP, and probably also on the tail of that, going to have the vaginal ring. So what is the vaginal ring? Right now, the ring we have is filled with Dapivirine. It is a flexible and self-inserted silicone ring that people can learn to do. It's got 25 milligrams of Dapivirine, which is a non-nucleoside reverse transcriptase inhibitor, NNRTI. It's intended right now to be changed monthly. One of the issues that we'll talk about a little bit, and maybe more, is that it has limited absorption, which means it's good for side effects. It has few side effects, but it also has limited absorption and cross into rectal tissue. So it is really only for folks who are at risk for HIV from vaginal sex. It was developed by the International Partnership for Microbicides through a license from Janssen. But it is the International Partnership for Microbicides that is really pushing this work. So the status of it is that open label randomized clinical trials I'm going to share with you have been done. The open label follow-up studies have been completed. There's, of course, additional work that is being done. The vaginal ring was recommended by the WHO in January of this year. And as I mentioned, it is under review by the U.S. Food and Drug Administration as of March. So we are going to talk about two main studies that were done as randomized placebo-controlled trials to show the efficacy of the vaginal ring. The first was the Aspire trial that was led by Jared Baton from here at the UW. The other was the Ring study. They were both published in the, that can't be right, New England Journal of Medicine in 2016, and it certainly could be right at this point, long time ago. But efficacy, reduction of risk associated with use of the vaginal ring in the Aspire trial was 27% compared to placebo, was 40% in the Ring study. Now, remember back when iPrex came out, the efficacy was just around 40% in the modified intention to treat analyses. So these numbers are low, but there's more details that are going to make it more optimistic. And the first of this is the breakdown in the efficacy of the ring by age. I believe this is the Aspire trial. What you see in this first set of Kaplan-Meier is the rate of HIV acquisition, cumulative incidence on the y-axis over time on the x-axis. You can see that these meet in the solid, the active drug versus the placebo. So no efficacy among young women between 18 to 21. But there was, you can see, a significant difference in the number of HIV infections, many more in the placebo group among women who were 22 to 26 and in women who are older than that, 27 to 45. So what they're saying is that among women who are over 21 in this study, the protection effectiveness was 56%. Does this mean that it doesn't work in young women? It's just, it's an age thing. You have to be older for it to work? No. What it means, just like we know from oral PrEP, is PrEP works if you use it. PrEP doesn't work if you don't use it. And so we're pretty comfortable right now thinking of what does it mean to be adherent to oral PrEP using levels from dried blood spots. But what they use for measures of adherence in the Dapivirine ring is when women return the ring, they estimate how much Dapivirine had been released if you used it for 28 days, and that is 4 milligrams were released. If you remove it before those 28 days are up, you will have more Dapivirine remaining in the ring, so less has been released. And what they're using is this measure of 0.9 milligrams are considered to be non-adherent. Again, more Dapivirine remaining in the ring when it was returned and measured. So in, again, Aspire, in the placebo group, the incidence of HIV was 4.2 per 100 person years, I'm guessing. Sorry, I didn't include that in the slide. Compared to individuals who had been randomized to the active ring, but who were felt to be non-adherent. Compared also to any level of adherence. In the paper, they split it down to folks that were moderately adherent versus those who were high adherent, and there was no difference in the group. But you can see that there is some reduction in incidence in the group who were at least moderate adherers for a protection of about half. But individuals who were non-adherent or had low levels of adherence had very little protection from the ring. Again, this is not surprising to anybody, right? You have to use these technologies. You have to take your pills. You have to use the ring in order for it to work. Side effects, I mentioned a second ago that there are few systemic side effects. It's generally, they are well tolerated. Some of these women had abnormal bleeding, some had some pelvic pain or lower abdominal pain. In general, this is well tolerated. The other concern that folks have is NNRTI resistance so the question is, among the individuals who acquire HIV while using the ring, are they more likely to acquire or to have acquired HIV drug resistance? And so in both the Aspire and the Ring study, there was no difference in the individuals who acquired HIV in the Dapivirine ring, and Dapivirine is being abbreviated as DPV, compared to placebo, 12% versus 10%. In the Ring study, it was similar. 18% of the women who acquired HIV had drug resistance compared to 16%. So no difference in drug resistance among individuals who acquire HIV while using the ring. This is a busy slide. This is examples of the 2 of the open label extensions. Reversed them here. So this is the DREAM study that was the follow-up to the Ring study, and HOPE, which came from Aspire. Out of Aspire comes HOPE. So those 2 studies now in open label extension, we know that when these happened, we knew, and the women knew, I say we, the global we, the women knew that there was some protection benefit. And I'm just going to jump down and point to these 2 numbers here, that in the DREAM open label extension, that women who used the Dapivirine ring had a 62% reduction in HIV incidence compared with their expected incidence based on the placebo arm from the Ring study. There was no control group in the DREAM study. similar to 39% in HOPE, again, the follow-up to the ASPIRE study compared to the placebo arm in ASPIRE. I share these two numbers because they are higher than the efficacy numbers from the ASPIRE and RING study, similar to what we've seen in open label extension for oral PrEP, because again, women knew that this worked and therefore they were probably more likely to be adherent. So we see it's sort of one of those things in real life that the effectiveness looks higher than what we saw in the efficacy trial because, again, people knew it worked and therefore they were more likely to be using this. And one other study I want to share, which is the REACH study. And the reason why I want to share this is that this is a study that's a crossover study between the ring and oral PrEP. And it's going to show us some of the differences in both acceptance and in persistence in these women over time. So again, it's within the MTN, which is the Microbicide Trials Network, crossover study. So some women get randomized to start the ring first and then go to oral PrEP, some the reverse. And I just want to show you again, I think it's 3 slides around adherence and acceptability and persistence. This first one is adherence. Green is going to be ring, blue is oral PrEP. Again, it's going to be FTC TDF and daily PrEP for those. And you can see it's about 50-60% in these two groups who reported that they were adherent and who met these 2 criteria. Again, can't be compared because these are 2 different ways to measure adherence, but still adherence was decent in these 2 groups. But I think it's in acceptability that we're going to see some difference. So over on the left is ring acceptability, green is acceptable, blue not acceptable. Most women thought that use of the Dapivirine ring was very acceptable, slightly lower for acceptability of over PrEP. Again, these are the same women who have used both of these methods. And then thinking about of these, what proportion of these women were fully compliant to either the ring or oral PrEP. Among women, full compliance is considered 6 or more doses a week. This is different than in cisgender men where 4 doses is considered sufficient. So full compliance is in this light color here. Dark color, which is about 50% of the women fully compliant to the ring, whereas less than a quarter of the women were fully compliant to oral daily PrEP as measured by dried blood spots, showing a estimated number of doses per week of 6. And then there is a lot coming along the pike in this field. So right now, as I mentioned, the Dapivirine ring has to be replaced every month. There are individuals, researchers working on 3-month duration rings that don't need to be replaced except every 90 days. And then as probably many of you know that there are multi-purpose rings that are combining HIV pre-exposure prophylaxis with contraception. And then there are others that are a little bit further behind that are working on STI prevention in addition to HIV pre-exposure prophylaxis and contraception. So trying to give people more options. So in conclusion, Dapivirine vaginal ring currently at the FDA for possible approval. It's unclear if it gets approval, how quickly it'll move to market since the product isn't currently available, but eventually likely will happen. But like with oral PrEP, efficacy is dependent on adherence. Adherence at the current dose and the monthly replacement may not be as high, even in perfect adherence, as it is to oral PrEP. There's a sub-analysis post hoc that was done of the ASPIRE trial where they looked at self-reported receptive anal intercourse as a possible explanation for why efficacy was not 100%, and there was no difference in the 2 groups. So the imperfect efficacy of the ring can't be attributed at least to self-reported receptive anal sex, with, again, the vaginal ring only protecting receptive vaginal intercourse. acceptability and persistence may be higher overall for women, at least in sub-Saharan Africa. But I think really it's about having more options and giving people more choices. So I'm really glad I got a chance to explore this field. Hopefully I've given you a good intro to this, and I'm happy to take any questions and we'll try to answer them.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.